and save 40 million lives over the next 4 years. Through a series of events, WHO has received 70 pledges worth $1.7 billion. Of this pledge, 39 are first-time voluntary contributors to WHO, including 21 from middle-income countries. Some of the world's poorest countries have contributed because they see the value that WHO makes on the ground. Along with other funding agreements and partnerships, we can now count on at least $3.8 billion, or 53% of the voluntary contributions needed for the next 4 years. This is truly significant because for decades, only a small portion of WHO's total budget was predictable. The funding from the investment round gives us more predictability and flexibility and the ability to respond rapidly to continually evolving health threats around the world. I thank all countries and partners who have contributed. Now to Mpox. Last Friday, the Emergency Committee met and advised me that the outbreaks of Mpox in Africa continue to represent a public health emergency of international concern. I accepted that advice. Yesterday, the Emergency Committee issued updated temporary recommendations, adding some new recommendations and extending or modifying others. As we have said many times, we're not dealing with one outbreak of one virus, but several simultaneous and overlapping outbreaks of different strains or clades of the virus affecting different groups in different places. So far this year, 20 countries in Africa have reported more than 14,000 confirmed cases, including 55 deaths. More than 75% of all confirmed cases and deaths in Africa this year have been in the Democratic Republic of the Congo, where the outbreak of Clade 1b has now spread to 6 provinces, including the capital, Kinshasa. Clade 1b has also spread to 4 neighboring countries. In Burundi, more than 2,000 cases have been reported, largely in urban areas. In Uganda, there are 649 cases and a fast expanding epidemic. In Rwanda, 37 cases have been confirmed, and in Kenya, there are 19 cases. And cases have also been reported in at least 8 other countries in Africa, the Americas, and Europe. WHO, Africa CDC, and our partners are continuing to support countries to respond to these outbreaks and prevent further ones under one joint continental preparedness and response plan. Together, we're strengthening the 5 C's of outbreak response: coordination, collaborative surveillance and detection, community protection, care that's safe and scalable, and countermeasures, including vaccines. So far, 6 million vaccine doses have been pledged, of which 1.6 million are ready for distribution by the end of the year. Almost 56,000 people have been vaccinated in 7 provinces of the DRC, and health officials there are preparing to administer a second dose with vaccination starting in Kinshasa this week. We still face many challenges to bring these outbreaks under control. To meet them, we need stronger political commitment to scale up responses, activities. We need fully resourced preparedness and response plans. We need further contributions of medical countermeasures, including diagnostics and vaccines. And we need continued transparency and collaboration between affected countries and partners. WHO welcomes the ceasefire between Israel and Lebanon that took effect yesterday, and we very much hope it's respected and becomes a lasting peace. Although the fighting has stopped for now, the health needs are huge and will only increase. Those needs are more acute now that winter has arrived. In Gaza, a year ago, almost all those displaced by the conflict were sheltered in public buildings or by family members. Now, 90% are living in tents. This leaves them vulnerable to respiratory and other diseases. Cold weather, rain, and flooding are expected to exacerbate food insecurity and malnutrition. At the same time, the ongoing blockade of northern Gaza is limiting the entry of essential resources, including blankets, fuel, and food, all of which are already in short supply. This week, WHO and our partners conducted a 3-day visit to the north of Gaza. The team visited 13 health facilities, including 5 hospitals. They saw a high number of trauma patients and increasing number of patients with chronic diseases needing treatment. There are critical shortages of essential medicines and significant psychological stress among health workers. WHO and our partners are doing everything we can, everything Israel allows us to do, to deliver health services and supplies. One of the most important ways that happens is through emergency medical teams made up of health professionals from around the world who have volunteered to serve. So far, WHO has supported the deployment of 45 teams from 25 partner organizations. Since January this year, they have delivered more than 2 million consultations. Once again, the ultimate solution to this suffering is not aid, but peace. As we always say, the best medicine is peace. Monday this week marked the start of WHO's annual 16-day campaign to draw attention to gender-based violence, which affects at least 1 in 3 women and girls globally. It harms women in all countries and cultures, but some are more at risk, especially those living through wars, conflicts, and other humanitarian emergencies. Often, sexual violence is used as a weapon of war, as it has been in Sudan. Armed groups terrorize women and girls in their homes, on displacement routes, in temporary shelters, or at border crossings. There are reports of kidnapping, trafficking, sexual slavery, genital mutilation, and child marriage. Many survivors face immense hurdles to access essential health and support services because of destruction of infrastructure, the danger of moving through conflict zones, or fear of stigma and reprisals. For the past 6 years, WHO has been working to address gender-based violence in 30 countries with humanitarian emergencies, with guidelines and training for health workers to manage rape and domestic violence. We have also supported ministries of health and partners to train at least 10,000 health workers in survivor-centered clinical care. All parties to a conflict have a responsibility to prevent and end violence against women and girls. It's preventable and never inevitable. Finally, this Sunday marks World AIDS Day. This year's theme is Take the Right Path, reminding us of the critical importance of human rights in the response to HIV. Since the first World AIDS Day in 1988, we have come a long way in expanding access to prevention, diagnosis, and treatment for HIV. But these gains are at real risk, and reductions in new infections and deaths have stalled. While nearly 30 million people are now on antiretroviral treatment, another 9 million need treatment and are not getting it. More than half of those, nearly 5 million, are still unaware that they are living with HIV. Many of these gaps are among key populations who are marginalized, criminalized, or discriminated against: men who have sex with men, people who inject drugs, transgender people, sex workers, and prisoners. The most effective way to close these gaps and reach these populations is by recognizing and respecting their human rights. Together, this World AIDS Day, let's take the right path. Let's take the right path. Margaret, back to you.
Thank you, Dr. Tedros. So I'll now open the floor to questions from journalists. But before that, just give you a reminder, please use the raise your hand icon to get in the queue. And if you've joined by Zoom, please make sure you've given your full name and your media outlet. We will only give the floor to bona fide journalists. And speaking of excellent journalists, we have Nina Larson on the line from AFP. Nina, the first question goes to you. Please ask your question. Unmute yourself and ask your question.
Thank you, Margaret. Thank you very much for taking my question. I wanted to ask about H5N1 bird flu and how concerned you are about the growing number of human cases in the United States, the detection in raw milk, and fears that this could potentially spark a new pandemic. I mean, there's been a lot of criticism of U.S. authorities for not doing enough testing. Do you think there is enough testing being done to give an accurate picture of what's happening on the ground? Thank you.
Thank you, Nina. I'll hand that question to Dr. Maria van Kerkhoff.
Thanks very much, Nina, for the question. So, yes, as you've pointed out, we've seen a large number, well, still small, relatively speaking, but a growing number of human infections of H5N1 around the world, not only in the U.S., but around the world over the last several years. What is concerning to us is that in the last 5 years or so, we've seen a massive epizootic of avian influenza, including H5N1, not just H5N1, but in wild birds, in poultry, expanding to other animals, livestock, dairy cattle in the United States, but also land mammals, marine mammals. And over the last couple of years, this expansion of H5N1, of avian influenza, is putting more people at risk. We have had about 55 human infections in the U.S. this year. All of 2 have had exposure, known exposure to infected animals. There are many investigations that are underway looking at the exposures of each of these cases to determine how people have been infected. But what we really need globally, in the U.S. and abroad, is much stronger surveillance in animals. In wild birds, in poultry, in animals that are known to be susceptible to infection, which include swine, which include dairy cattle, to better understand the circulation in these animals. We need much stronger efforts in terms of reducing the risk of infection between animals, to new species, and to humans. And to do that, we need to protect people who are at risk, people who are exposed. So these are occupationally exposed persons, making sure that they have the right personal protective equipment, that it's worn appropriately and properly when they are handling infected animals or even suspected infected animals. We need to make sure that they have testing, that they have access to care, so that we can mitigate any potential spread. We have not seen evidence of human-to-human infection. But again, for each of these human detected cases, we want to see a very thorough investigation taking place, including further testing of contacts. Excuse me, I've been a little unwell over the last couple of days, so it's hard to speak. We need serology to be done among the contacts so that we can really understand the extent of exposure. We've reached out to our partner agencies at WOHA and FAO to try to increase the urgency as it relates to surveillance in animals, to make sure that we are all working towards a common goal of preventing, the next pandemic. For us at WHO, we are always in a constant state of readiness as it relates to influenza, because it isn't a matter of if, it's a matter of when. And so the work that we do through the Global Influenza Surveillance and Response System, but also our PIP framework, our Pandemic Influenza Preparedness Framework, and looking at access to medical countermeasures like vaccines, diagnostics, therapeutics, gets us ready for when or if we will be in a situation where we are in a flu pandemic. We're not in that situation yet, but we do need more vigilance. We need more collaboration, more transparency across the human health sector, the animal sector, the environmental sector, so that the risk assessments that we do can be regular, can be robust, and that we could do them on a regular basis. But globally, the risk to the general population for avian influenza is low, but it's low to moderate for occupationally exposed people. And that moderate level depends on the level of protection that they have. I do want to just comment on the work related to milk. We recommend, and we've always recommended, drinking pasteurized milk for a number of different health benefits. This is just as important for H5N1 as it is for other pathogens, other bacteria. So that continues to be a recommendation from us.
Thank you very much, Dr. Van Kerkhove. The next question goes to Mohammed from Andalou. Mohammed, please unmute yourself and ask your question.
Margaret, thank you so much for taking my question. As Mr. Tedros mentioned, ceasefire started yesterday between Israel and Lebanon. There were Israeli attacks on Lebanon from end of September until yesterday. My question is, in this process, how many healthcare workers were killed, and how much healthcare system affected in Lebanon? Thank you.
Thank you. Mr. Nabil Tabal will take your question.
Thank you, Margaret. In WHO, we have the surveillance system for attacks on healthcare, which is a reporting and monitoring system that uses a robust methodology to verify the attacks on healthcare, and that was established during the start of the escalation last year in October 8th. And since that, we have recorded 160 attacks that led to the killing of 241 people and injuring close to 300. And that has really affected also the operational status and the structural damage also to the hospitals and the primary healthcare centers. Almost 10% of the hospitals were affected, whether completely became completely unoperational or partially operating at a partial capacity, prioritizing only emergency care. And several hospitals and PSCs have also suffered structural damage. So this is up until the ceasefire, and work is also now ongoing on, especially with the start of the ceasefire, to re-operationalize the hospitals that were affected in all across the countries, and especially in the conflict affected areas. So especially with the return of IDPs to the conflict-affected zones in the south, in the Bekaa, so that we can ensure also the continuity of essential healthcare to the returnees. Thank you.
Thank you. And we also have our representative in Lebanon who's joined. Oh, yeah. He's not joined yet. Maybe Dr. Michael Ryan will just make an intervention while we're waiting.
I just whatever what Nabil said was great. I just want to add that it's fantastic to see the prospect of people returning to their homes on both sides of this conflict. There's been displacement for many, disruption for many, and it's really important that peace is maintained, because civilians are returning already. It's very important that their return is respected by all sides, and they get to re-establish their communities. So we welcome that, and as Tedros always said, peace is the best medicine, so let's hope this holds. But it doesn't take away, in a sense, that's really important, and Tedros again said this in his speech, the horror that's unfolding in Gaza. What has happened in Lebanon has been a terrible tragedy, and this peace is fantastic. But the attention must now move urgently to Gaza. We have to stop the fighting in Gaza. The situation is catastrophic. The system is under huge pressure, and on the health side, and maybe our rep Rick will speak to this, hugely brave health workers, international emergency medical teams, WHO and other UN staff, keeping that system going in an incredible way. So I think it's really important that whatever has been achieved now is secured in the Lebanon-Israel conflict, but that we have the same process achieved as quickly as possible for Gaza. Maybe Rick from OPT wants to speak on that.
I think we have both. So maybe we'll start with Dr. Abdi from Lebanon and then move to Dr. Peppercorn as well.
Thank you very much, Margaret. I think, Nabil have already shared some of the figures, but, first we welcome the ceasefire, and I think the ceasefire provides an opportunity, and it's a critical window to address the urgent humanitarian needs. And I think what's more important is that the scale of the healthcare challenge remains enormous. And I think from now until the next few months, I think we have to try to reestablish the health services in the conflict-affected areas. Almost 1 million people now are moving back to the south and the east. And some of those returnees and some of those displaced people might not have homes because some of the village has been destroyed. Primary healthcare facilities need to be reestablished, renovated. Medicine should to be provided, but also as a WHO, we are working closely with the Minister of Health how to facilitate the return of healthcare workers as well. As you know, that many healthcare workers were also displaced from the south and from the east, and also we need to facilitate that. I think the most critical aspect is how to reestablish the healthcare services in those conflict-affected areas. Of course, it will take some time. But I think we are working with the partners, with the Minister of Health to make sure that health services are available for those people who are returning to the conflict-affected areas. But again, of course, we welcome the opportunity that this might lead to the prolonged and long-lasting peace, and we are very hopeful for that. I think that all the displaced people, they are very happy to see the ceasefire, and I'm sure. All of us are very happy to see that the prospect of this peace will prevail, not only short term, but in the long term into that. Thank you.
Thank you very much, Dr. Abu Bakr. And now we'll also hear from Dr. Rip Peppercorn. As Dr. Ryan mentioned, there is a great deal to add.
Thank you very much, Margaret and colleagues. I just want to refer to the introduction by the DG and maybe even not start about health, but let's say with winter approaching and being more than close to 14 months in this horrific crisis, we are back that we are discussing the basics of humanitarian support. So the first top priority is actually fuel at the moment again. So we're talking again about the lack of regular supplies of fuel. Without fuel, no humanitarian operation at all. We also, again, are back in discussing food. There's again massive food shortages in Gaza, both in the south with skyrocketing prices for whatever is available, and in the north. The third area is shelter. Deeply concerned about shelter, or what they have also the shelter kits to make sure that even the ad hoc tents are better, more waterproof, etc., to get them in. Non-food items, tarpaulins and everything related to that. For me, and just having been more than almost 4 weeks in Gaza and going next week again, these are the top priorities, linked to, unfortunately, what we have seen, a huge increase in insecurity, crime and looting. So this is a an absolutely topic. Now, going back to specifically on health, and I'm glad that Mike mentioned, I often get the question, oh, health service completely collapsed in Gaza. That's not true. I want to make that very, very clearly. And I think it's the incredible resilience of the health workers, Ministry of Health, WHO, and partners who've kept a system, I call it partly functional. And we all know that in February, for example, WHO had to assist getting the last patients out of National Medical Complex and the staff out, evacuate. The same happened in Shifa, European Gaza, etc. All those hospitals are again working as a referral hospital, not as we want them, but partly functional. And we are even referring patients there for better treatment. However, in the north of Gaza, and we have raised this many times, there's only 2 hospitals left for approximately 70, 80,000 people left. Kamal Adwan and Al-Ada. And those hospitals, there I cannot call them partly functional. They're minimal functional. Kamal Adwan has 1 or 2 specialists, the director, Dr. Hussam, pediatrician, who, by the way, was recently injured through an attack on the hospital, run by a few doctors and 70 nurses, still has 55 inpatients among 13 children and 5 in the ICU. The hospital has fuel for 1 or 2 days and is in dire need for an emergency medical team, blood units, medical supplies, food and fuel. Now, Al-Ada Hospital, where I've been also many times, even they have, if their fuel stocks is 0. They get a lot of obstetrics and trauma. It's one of the only hospitals with actually a surgeon, it's the only one with a surgeon north of Gaza. And so are in need for everything. So in November, WHO planned 22 missions. Only 9 were facilitated. The last 5 in the same time, 5 missions were denied to provide supplies, fuel, and bring an EMT to Kamal Adwan. Only a few, and one of the few you heard about, we managed. Coming Saturday, we plan another mission, and we hope everybody is listening and that this mission will go. And it should go not only to Kamal Adwan, it should also go to Al-Ada. Now, the cluster mission under leadership of WHO, I think, was a success. Critical supplies to Shifa Hospital, the patient-friendly hospital, UNWA, Primary Healthcare Center, and MSF Primary Healthcare Center, all in Gaza City. There's a need to expand the service in Gaza City, because Gaza City, actually, there's another, between 100 and 150,000 people from the north are now actually camping in Gaza City. What they assessed, a huge need for mental health, psychosocial support, especially also for the health workers, and of course the shortages in supplies, the staffing, but also the high influx of trauma patients, and the shortages remain in the key area: analgesics, antibiotics, surgical supplies, oxygen, IV fluids, etc. So we have that. The same applied for the primary healthcare assessments, where you see similar shortages, more of basic diagnostic equipment and chronic disease medication, etc. Now, again, I want to stress WHO is ready to do more missions to bring some of those much needed supplies and fuel, including emergency medical teams. That should always be allowed. It should be even, it's weird that we continuously discuss these topics in presses like that. So we hope that we will make inroads. But I want to stress the other key humanitarian areas which I mentioned, I'm currently even more concerned about. Maybe a last positive, just the day before yesterday, WHO facilitated another medevac of 70 patients to Jordan for special medical treatment. 12 will receive care in the US, and 6 of the patients required cancer treatment, and 11 needed treatment for war injuries. So since Rafah crossing closed, we have been assisting almost 300 patients moving to better places. What we of course asked for is consistent medical corridors And first of all, a restoration of the medical corridor to the West Bank and East Jerusalem, but also into Egypt, etc., because approximately 12,000 patients need to be referred out of Gaza. And if we continue in this pace, we will be busy for the next 10 years. Over to you.
Thank you very much for that really comprehensive summary of the situation, Dr. Peppercorn, and also thank you, Dr. Abu Bakr. The next question goes to Yuri from Novosti, RII Novosti. Yuri, please unmute yourself and ask your question.
Yes, thank you, Margaret, and thank you for the briefing. I just wanted to know if you have more information on the possibilities that have WHO in Lebanon during these 60 days to, I don't know, to work in the hospitals that were closed during the conflict, to provide everything that is needed in the south of the country in order to close the gap in the humanitarian reaction during the hot period of the conflict. Thank you.
Thank you. I think we did answer some of that, but perhaps we'll go over it a little. Would you be happy to start, Nabil?
Yes.
Oh, sorry, WR is still online. Sorry, I thought he'd left. So that's great. Is he still online?
Yes, I'm online.
Oh, brilliant.
Yes, actually, yes, we are trying to take advantage of this. And I think one of the first things that we have decided, for the last 2 days, together with the Minister of Health as well as other partners, is to do a quick assessment of the hospitals and primary healthcare facilities, the extent of the damage, because some of those hospitals, they have a very extensive damage, which cannot be repaired, which cannot be renovated within 60 days, within even 6 months. There are some hospitals which requires a minor renovation, but also some minor equipment. Same thing with the primary healthcare facilities. So I think we decided to do a quick assessment together with the Minister of Health and also the local health authorities. And then we will take some action to renovate and also, procure some of those equipment. Probably some of our hospitals will take some time, but some hospitals probably will be able to restart very quickly. For example, there are 4 hospitals, 2 in Beirut, 2 outside Beirut, that probably will be able to operationalize for the next 4 weeks if the ceasefire remains intact, and also if the security allows us to move around, there is no restrictions. So we are very hopeful. But at the same time, also, we do have a backup plan where we are trying to increase the mobile clinics that will be serving for the displaced people who are returning to the conflict-affected areas. So at least they will have access to services in overall. So overall, I think we have a master plan that for us to help all the hospitals and primary healthcare facilities and all the health services to restart most of the conflict areas. But I'm sure to kickstart all the services 100%, it will take some time. But definitely, we do have a backup plan to at least to provide the critical health services for those area and those displaced people who already returned to conflict-affected areas, especially the hospitals.
Thank you very much for that really comprehensive answer again. We now have a question from John Zarakostas. John, please unmute yourself and ask a question.
Yes, good afternoon. My question is to Dr. Tedros and Dr. Ryan. Some of the humanitarian agencies have already put out what their ask will be for 2025. The World Food Programme have mentioned their figures, and the UNHCR. I was wondering what will be the ask from donors for humanitarian relief and support in the health area in 2025. Thank you.
Thank you. Over to Dr. Ryan.
Yeah. John, that's we're currently finalizing with the country offices and with our partners the ask from both WHO and also from the health cluster partners as part of the humanitarian health appeal, and that's feeding into the global humanitarian overview, which I'm sure you'll be awaiting with bated breath. Thank you. I think it's a good question to ask. I think the question is less what are the humanitarian community going to ask for, because it is very clear that the needs are growing, and the needs are growing exponentially in some situations, and the complexity of the crises we're all collectively facing, the interface now between conflict, displacement, climate, and epidemics, or sometimes I call it the climate contagion and conflict, have just finally ripped through so many countries that countries are just not recovering. And what we're seeing is a new pattern, John, and you've seen this yourself over the years. We've moved from a series of acute humanitarian crises where there's a beginning, a middle, and the end of a crisis, be it a natural disaster, be it a conflict. What we're seeing is countries rolling over in crises, going from one crisis to the next, be it from a political to economic, to a climate, to conflict, to an epidemic, and countries are just not pulling out of that. And we're seeing the length and of these crises increasing. The duration of these crises is not measured in weeks anymore. It's not measured in months. It's measured in years, and in some cases measured in decades. And therefore, humanitarians have to stay in the ground, on the field. This move between humanitarian intervention and development has been interrupted and disrupted in country after country. It's very impossible. It's nearly impossible in some situations to reignite development activities in many geographies. So the humanitarian needs are growing, but the real question is how much money does the international community have to give? Because that's been falling. So while the rate of crises and the depth and intensity of crisis has grown, the appetite of the international community to fund those has fallen away. And we're seeing that in crisis after crisis last year, and many of the humanitarian health appeals last year were less than 50% funded. Some of them were less than 20% funded. There are a couple that are less than 10% funded. It is very, very hard for WHO and its health partners to deliver on any of the ambition that we have with those kinds of funding numbers. Last year, I think the overall ask was in excess of $1.5 billion to deal with all of the crises. That doesn't take into account the operational costs that WHO has to have our offices on the ground in countries and all of the infrastructure that goes with that. That is an extra cost on us. So what are we asking? And Tedros keeps saying this: we can keep asking for money, we can keep asking for resources, but when you look at it, the realities on the ground are we keep asking for more money, the number and depth and intensity of crisis grows, then we ask for more money, and then it goes around and around. What has to happen is something has to be done politically to interrupt these crises. We have got to have a much more fundamental intervention that prevents countries going from fragility to collapse, that prevents populations going from being in homes to being displaced, that prevents communities that are well protected with vaccines going to massive epidemics. We're shifting huge elements of our societies from stability to instability. And while we continue to do that and leave hundreds of millions of people outside what is the developed world standards, and this is no longer a developed world to developing equation. There are many developing countries, or so-called developing countries, who are making great progress. They're stable, their vaccination rates are rising, their education rates are rising, women's rights are being addressed. It's not perfect, no country is perfect, but we're seeing progress. But there is a group of countries where they seem to be separating from the rest of the planet geopolitically, where they're having these permanent state of crisis, and literally we're going, every year we're nearly doubling the number of people who exist in those settings. We believe by the end of the decade that up to 80–85% of the world's poorest people will live in these fragile, conflict-affected and vulnerable settings. We think that 2/3 of women, or over half of women, over half of children who die in before 5, over half of women who die in childbirth will die in these settings. 70% of high-impact epidemics will die in these settings. That's what's driving migration. That's what's driving desperation. That's what's driving global epidemic risk. And we don't seem to be able to get to grips with that. So, John, while I respect the question, I really appreciate the opportunity to reach out to our donors to ask for more money. More money is great and we need it, but more money is not the solution to what we're all facing right now.
Thank you very much, Dr. Ryan. And I think, oh, Dr. Tedros has something to add. No? No, I was going to say, I'd like to ask Dr. Tedros to end the press conference because on that note, I think that's the note on which we end.
Thank you. Thank you, Margaret. Thank you to all members of the press for joining us today, and see you next time. Thank you.